Coming up from the American Heart Association, it's the latest episode of Connect with the CEO. Today's topic, protecting you, your family, and young athletes through COVID-19 research. I'm Greg Donaldson, the Heart Association's Senior VP of Corporate Marketing Communications. And during the next hour, we'll hear from leading global experts in a future-forward conversation focused on what we've learned so far about the impact of COVID-19 on cardiovascular health. Specifically, we'll take a look through the lens of AHA's COVID-19 CVD registry and discuss unusual cardiac disorders in young athletes revealed through the novel research being conducted in the Outcomes Registry for Cardiac Conditions in Athletes, a collaboration of the AHA and the American Medical Society for Sports Medicine. As a reminder, we encourage you to join the conversation and submit your questions during the live program. You can email them to askaha@heart.org, and we'll answer as many as we can in the time that we have. We'll get to your questions and answers shortly, but first, let's introduce the host for today's program. As always, it's my pleasure to introduce the American Heart Association's Chief Executive Officer, Nancy Brown. Nancy will moderate today's conversation and provide us a deeper glimpse of the American Heart Association's relentless and continuing impact, even as our society continues to navigate the ravages of COVID-19. Since 2008, Nancy has elevated the Heart Association to become the preeminent global leader in heart disease and stroke science innovation. Under her leadership and as part of a career spanning 3 decades, Nancy continues to lead the association in pursuit of its mission of serving as a relentless force for a world of longer, healthier lives. The work of today's American Heart Association leverages the power of more than 40 million volunteers, scientists, staff, and donors. Hello again, Nancy.
Good afternoon, Greg, and thanks to all of you for joining us for this month's Connect with the CEO. I especially want to thank the members of our Core Vitae Society and our Paul Dudley White Legacy Society for being with us. We are so grateful for your ongoing support of our life-saving mission. We really have a special treat for you today, and just to frame that up, let me make a few comments. I think many of you know that since the beginning of the coronavirus outbreak, the American Heart Association has rapidly responded. We've stood up rapid action research grants that we've talked about in this venue before. We've delivered solutions to healthcare heroes on the front line, and we've shared information and resources. We're also providing ongoing resources to stop the spread of the virus, especially for heart and stroke patients, caregivers, and underserved populations. We've made significant investments in advocacy, community outreach, and community education. And sadly, as we know, to date, millions of Americans have been impacted by COVID-19, leading to over 500,000 deaths. People continue to struggle financially. Healthcare workers and healthcare systems are still overwhelmed, and life as we knew it has changed dramatically. But there's also reason for hope and reason for optimism. The American Heart Association is diving deep into the science of COVID-19 thanks to our dedicated supporters and our generous donors. Science is the foundation of the American Heart Association, and we have nearly a century of experience using research to help patients with heart disease, survivors of stroke, and millions of other people striving to live healthier lives. In the fight against COVID-19, our science focuses on 3 critical areas: our patient registry, our research grants, and our work in resuscitation. I remember as if it were yesterday getting a phone call from one of our guests today, Dr. James DeLamos, back at the end of March 2020, with his idea to create a COVID-19 patient registry for in-hospital patients that would give researchers much needed health data to solve big unanswered questions and provide clinicians new insights on treating COVID-19 patients with cardiovascular disease. We're going to hear more about this registry in just a few moments from Dr. DeLamos himself, and we'll hear more broadly about how the AHA is using registry programs to make a difference. But I can say already that the volume of data that we have collected in this past year from over 164 hospitals has been incredible, and it's leading to papers that we have or will be publishing very soon. And in addition to our COVID-19 CVD registry, we're so proud that the American Heart Association and the American Medical Society for Sports Medicine recently joined forces to establish a national registry to track COVID-19 cases and CVD in NCAA athletes. Called the Outcomes Registry for Cardiac Conditions in Athletes, or ORCA. We have already collected data on more than 3,000 athletes. Just to frame this, nearly 500,000 NCAA student athletes, more than ever before, compete in 24 sports every year. Additionally, millions of young athletes are enrolled in youth sports. And with March Madness just around the corner and many sports leagues back in action, we are committed to support athlete safety and the health and well-being for all people by understanding the short and long-term impact of COVID-19. So let me introduce, without any further ado, the very special guests who are joining us today for this conversation on how these two registries will provide answers to better treat COVID-19. Let me start by welcoming Dr. Dan Jones. Dan is a past president of the American Heart Association. Although he is retired now, he's had an incredible career in medicine. He's led a large academic medical leadership and also a large university. He remains active as an American Heart Association volunteer, serving on a number of national committees, and has been actively involved in our collaboration around the Athletes Registry. Dan also is serving as our volunteer leader for our work in healthcare access and advocacy. And Dan's research expertise is on the prevention of cardiovascular disease and the elimination of racial and economic disparities in health outcomes. Dan, thank you for joining us from Mississippi. We're glad to see you today.
Nancy, thanks so much. It's a privilege to be a part of this panel.
Thank you. I'd also like to welcome Dr. James DeLemos. Dr. DeLemos is an author and co-chair of the AHA's COVID-19 CVD registry and really the brainchild behind the registry. He is also professor of medicine and the Sweetheart Ball Kern Wildenthal Distinguished Chair in Cardiology at the UT, University of Texas, Southwestern Medical Center in Dallas. James has a research interest in the early detection, risk assessment, and cardiovascular disease management, with a particular focus on the role of cardiovascular biomarkers. Welcome, James.
Thank you, Nancy. It's a pleasure to be here.
And finally, I'd like to welcome Dr. Kimberly Harmon. Dr. Harmon serves as a primary investigator for the Outcomes Registry for Cardiac Conditions in Athletes. Dr. Harmon is the section head for sports medicine and professor of family medicine, orthopedic surgery, and sports medicine at the University of Washington. Her clinical interests include the incidence and causation of specific diseases, prevention of sudden cardiac death in athletes, such an important topic. Welcome, Kim.
Thank you very much. It's great to be here today.
We are just thrilled to have all three of you here. And, you know, I think it's important if we start by framing the American Heart Association's background in registries overall. And Dan, I wonder if I could start with you. You know, back when you were president, we won't date either of us, but it was many years ago, several years ago, we'll say that. You know, the American Heart Association's work in registries was, you know, on an upswing and has continued to be such a prominent part of the work of the AHA. Could you give us your perspective on that?
So the story of the registries really is quite amazing. In my time of leadership, and the conversations were taking place that this was a way to fill a research gap, the use of registries. I'll have to say I was uncertain about how valuable the registries would be. Boy, have they ever been effective. These registries form the basis for understanding heart disease better, especially the acute events of heart attack and stroke. And the use of the registries, along with what has followed from the registries, from that information, the American Heart Association produces guidelines. And from those guidelines, care standards for patients. And from that, programs that award good performance and also try to improve less than ideal performance. And these programs, including the registry and Get With the Guidelines, have been transformational in the acute care of heart attack and stroke.
Yeah, I always like to remind people as an example of the prominence of our Get With the Guidelines suite of quality improvement programs and registries that almost 80% of every stroke that happens in this country is documented in our Get With the Guidelines stroke registry. And I think that shows the tremendous reach and the impact in almost 2,300 US hospitals that our registry programs have. And so, James, back the end of last March, when I remember where I was sitting when I heard from you with this idea of using that infrastructure to help with COVID. Tell us a little bit, what was going on for you at that moment? You know, you are a very busy physician scientist at a very large academic medical center. Tell us about your vision behind the registry and what were you seeing in practice at the moment that this idea came to you and your colleagues?
You know, it was a time, Nancy, as you remember, of great uncertainty. We were getting these reports coming out of Wuhan and then Italy, and very beginning really on the East Coast in the United States of COVID maybe not being just a respiratory illness with potentially heart complications being important and patients having major heart issues that developed relatively late. But they were all coming in stories and anecdotes from, frankly, people that were doing heroic reporting on the front lines when they were being overwhelmed with COVID. And we were trying to prepare ourselves in Dallas because the pandemic hadn't hit. And in fact, many of our young trainees were deployed home, and they really led the charge locally. They helped us to understand what was going on with COVID, how people were learning to treat it, and what the cardiac complications might be, and built a local registry with some blood collection that really led us to understand what could be possible if we moved beyond a single center. And of course, you know, really leveraging off of what Dan talked about, we knew that the place that does this best, most effectively was American Heart Association. So we obviously came to you to talk about exploding this. And I, you know, to say that this exceeded our wildest expectations would be an underestimation. I think, you know, so much credit to the professionalism and ingenuity of the AHA staff that lead these guidelines. They all have full-time jobs, mind you. They're all running these other registries, and they in the midst of all that, they basically worked with our team of volunteer steering committees and stood this registry up in 3.5 weeks. Within 3.5 weeks of that phone call, they had a case record form. We were collecting COVID-19 cases from hospitalized patients. And within a couple of months, as you mentioned, this had expanded to 160 hospitals, 35 states. We've now got 40,000 patients enrolled. And it allowed us to answer questions not in the anecdotal, this is what I see, but rather get at what is really happening in hospitalized COVID patients, which is you know, a real necessary rigor to understand what's going on.
And, you know, James, one of the beauties of the COVID-19 registry is that we have been able to collect serial days of data on these patients. Could you describe the kinds of data we're collecting? And as we're thinking about solving through research and study the mysteries of what's happening to patients, either in the hospital or as they have, quote, long hauler symptoms, why is the data we're collecting important? How will it help?
Well, to understand disease in humans, you've got to collect what we call granular data. And a lot of what people were reporting were sort of superficial looks at the data, but we're collecting deep laboratory data on all of the patients, including heart injury markers, inflammatory biomarkers, you know, all of their heart history, and unique because this is a cardiovascular registry, all of the individual cardiac complications that occur during the hospitalization. And we can layer on top of that understanding of the heart medicines they were taking and received in the hospital, the blood clotting medications, and even the COVID therapies, and try to dissect what is driving these heart complications, what therapies doctors gave in the hospital that might mitigate some of the heart complications. And then, as you mentioned, start to think now about this next phase of COVID, really the long-term complications, by figuring out how to take this hospitalized data and link it to other data sources so we can figure out whether people who have, for example, elevations in injury markers of the heart in the hospital have long-term complications with their hearts later on.
Yeah. One thing that's been amazing to me, I'm not surprised, but I've been proud to watch the scientific community worldwide really come together around this pandemic and everyone gives everything they have to try to learn and solve and help with solutions. And I think a registry like the COVID-19 registry provides a real rich source of actual data for scientists who are devoted to understanding, in this case, the complications that might be experienced. So talk to us a little bit, James, about how we use this data. So we have this huge repository of data on tens of thousands of patients. What happens with the data, and how does that help us learn things that will help patients?
Yeah, and I'd like to, we actually had to think not just creatively and out of the box in terms of setting something up this quick, but we also had to think about how to get knowledge disseminated and transferred in really record time. As successful as the AHA registries are, the process to do research, publish the research, and lead to guidelines, that's a several-year process. And we realized that sort of serial research wouldn't work in a pandemic that we don't know anything about. So what we did is we leveraged a resource at the Heart Association called the Precision Medicine Platform, where once we got a copy of the database, we placed it on the Precision Medicine Platform, and we're able to allow multiple teams of investigators to work simultaneously on the same data set, asking different questions. So we were able to have, right now we have about 40 scientific proposals approved. Some of them use an academic center to do it. Some of them use professionals. The AHA has a wonderful team that can help investigators that don't have a lot of experience. But for many of our centers where we have lots of experience, the investigators themselves and their teams can go into the AHA's Precision Medicine Platform and ask and answer their scientific question without waiting for anybody else, and they can share best practices. And this has really, I think, led to a rethinking about the pace of research in general. What we've been able to do here, approve 40 protocols. Within 6 months, we had 2 published papers and some late-breaking presentations at the scientific sessions, and now we have about 15 completed papers in 8 months. We realize that research can happen much faster if we think outside the box, leverage some of the technology resources that AHA has invested very heavily in, and leverage all of the talent among investigators across the country, including AHA professionals who do this for a living.
And what have we learned so far from the data? You mentioned the 2 papers that were presented at scientific sessions, and others I know are in process of being published. So you probably can't tell us everything yet. We'll all hold on to get back with our friends on the call today. But what can you tell us about what we've learned? Yeah,
so we've had some two major papers that came out. One was focusing on the impact of obesity on outcomes in the pandemic. And the first thing we noticed was that people that were obese were much more likely to be hospitalized with COVID. So the first, obesity seems to have 2 lesions. The first is that if you're infected, you're more likely to require hospitalization. And then when hospitalized, obese patients were more likely to require going on a mechanical ventilator and to die. And importantly, we found that this association was stronger in young individuals. So the spike in risk that we see with obesity was particularly strong among individuals that were under 50, where the signal for premature death and the need for mechanical ventilation was really striking. We think that's a hugely important public health message because many young people have been led to believe that COVID's not a big deal for them. But that's definitely not the case for obese young individuals where the risk was really notably high.
And we also, I know, were able to document what we knew already is that there is a disproportionate burden of COVID-19 among Black and Hispanic communities. Could you comment on that, James?
Yeah, this is really a national tragedy for sure. And we saw in the first 3 months of the registry that 58% of patients hospitalized with COVID in this representative national registry were either Black or Hispanic, dramatically higher than rates of Black and Hispanic patients in the census areas where these hospitals reside. And over 50% of the deaths in the registry so far have occurred in Black and Hispanic individuals. Importantly, when we account for differences in patient populations, the risk of death and complications in the hospital doesn't seem to differ by race ethnicity. So there doesn't appear to be a quality gap with regard to treating COVID in the hospital. Really, this is a pre-hospital lesion reflecting things that we know all too well that were laid bare by the pandemic, inequities in access to healthcare, long-term consequences of structural racism and poor access to health in minority communities that have led to higher rates of COVID infection, higher rates of hospitalization and death. And it's a terrible national story, frankly, and something I hope that will catalyze long-term change.
Thank you, James. Dan, the two papers that were presented are right in your sweet spot. You've spent your life thinking about research in disparities. Hypertension is an area you may want to comment on. And I know in portions of your career, you have led work in obesity research at the University of Mississippi Medical Center. I wonder what you think of when you hear this data, or what did you think when you saw it? Because I know you were watching carefully back in November. And tell us what you think we need to do to protect these high-risk individuals from COVID. And you are on mute, Dr. Jones. We knew that would happen to some of us along the way today. So you just are the first one.
Yeah, at least I warned you. So,
Yes.
James used an important term, the term laid bare. So the issue of healthcare disparities around race, ethnicity, economic status have been known by scientists for a long time, but sadly don't get nearly enough attention in the broad public view of this. And I do think that one of the things that has certainly happened during the COVID pandemic has been forced people to face the realization that we're dealing with such difficult health disparities around race and ethnicity in our country, and that it's time for us to do something about that. Obesity is not unrelated to the issues of race and ethnicity and economic status. Race and economic status are strong markers for the presence of obesity. There are a number of social determinants that we understand, like educational status, family income, those kinds of things we know are important, but there's so much more for us to learn. And one of the things that excites me about the COVID registry is the opportunity for us to emphasize some of these long-standing problems that we've not yet fully understood, to merge the thinking of pandemic thinking with these chronic conditions like obesity and hypertension and diabetes and the underlying obesity problem, and to address those in a more meaningful way.
Dan, although this isn't a registry question, I need to ask you this question because, as I mentioned in our introductions, you are the volunteer lead for the AHA's advocacy work in our Medicaid expansion and access to healthcare. Could you talk a little bit about how having healthcare or not having healthcare, especially in a COVID era, determines the type of health outcomes you will have as an individual?
Nancy, it makes a huge difference. And there are communities that would surprise some in our listening audience and our viewing audience, that people don't have easy access to care. It's one thing to say, well, gee, there's a medical clinic over there. But if your family doesn't have the privilege of health insurance, then going to that clinic is not nearly as attractive as it would be if you had the ability to go and pay the bill. And so many of these patients who have chronic conditions like obesity and hypertension and diabetes wind up getting care in emergency rooms, which is such an inefficient way for our health system to provide that care, and so inefficient for our patients as well. And those chronic conditions go untreated or not adequately treated for years, leading to the premature cardiovascular disease that we see in people of color in our country. We just simply have to join all the rest of the industrialized nations in the world and not just talk about healthcare being a right, but to make healthcare an accessible right for every person in America. And Medicaid expansion is a key part of this. The complexity of the Affordable Care Act and the Supreme Court decisions that followed have placed a burden on communities that have difficult politics and have made it difficult to accept Medicaid expansion, but it leaves many, many, many people in our society in those states without adequate access to care.
Yes, and these are individuals of color, as you've mentioned. They're individuals who live in rural communities where healthcare access is not as obvious. And, the American Heart Association has penned 2 presidential advisories about the crisis of healthcare in these communities. And so, of course, a major area of our work. So I'd like to bring Kimberly into the discussion and switch the focus just a bit and talk about our collaboration with the American Medical Society for Sports Medicine. And as I mentioned, this partnership is to create a registry to answer critical questions about cardiac disorders in both COVID and non-COVID young athletes. And we're very excited about this. And I wonder, Kim, if tell us what you see as the biggest health concerns facing young athletes who get COVID. And maybe if you could give us a little color commentary about the registry, just the way James did about the COVID registry.
Yeah, thank you very much. I think when we talk about young athletes, what is really concerning about COVID is actually just the unknown. And particularly after some of the initial information came out this summer or early spring that there may be a predilection for COVID in the heart and in young athletes, that's particularly concerning. So I would say that cardiac concerns remain a primary concern that we're looking at with this registry. And then also additionally, in terms of young people with a huge amount of life in front of them, if there's going to be long hauler type symptoms in some of these young athletes. It appears from our initial data that these are both infrequent. They occur, but they're relatively infrequent. But really any type of morbidity in this very young and healthy population is concerning. And so we are particularly excited to have the sort of power of the AHA and the infrastructure of the AHA to work with from this. For years, we have been thinking about trying to put together a registry where we could keep track of people who had cardiac conditions and follow them long term. And really, this COVID pandemic has brought cardiac issues in young athletes to the forefront and really given us a platform to potentially accelerate doing this. And so we just could not be more pleased at being able to partner with the AHA and really take advantage of the infrastructure that is just amazing and will really help us move this along.
Well, we're so proud of the partnership as well. And one thing I think our listeners would be interested in understanding is how is the data being collected? And you've mentioned health concerns broadly. I know you have scientific expertise in sudden cardiac arrest. We hear all of this about myocarditis in younger people. So how will we collect the data and what exact health issues will we be able to study?
The sports medicine community is a relatively small community. And when initial reports started coming out about cardiac concerns, there were a bunch of us that were on committees or just calling up each other and saying, gosh, what are you seeing there in Alabama or Mississippi? And what are we seeing? And how are you working this up? And so this was really sort of born out of a boots on the ground sort of collaboration. And so very early on, we decided we needed to start sort of pooling our data so that we could understand this better. And we created a Excel spreadsheet with a bunch of different data variables on it, and athletic trainers, team physicians, oftentimes with little or no research background, are collecting this data and putting it into the spreadsheet, and then we're putting it into a database. And so there's really a lot of hard work and collaboration that is being done at each local university that's participating. And we have a lot of interest. Right now we have 42 schools that are participating, but certainly probably close to 200 that are interested. There's also, when you're doing research, lots of regulatory things that you need to do. And so having the ability to help smaller schools or schools that aren't doing a lot of research out of their athletic departments sort of jump through those regulatory hoops has been really, really critical, and where some of the first funding went to, just to have some people to handhold through those issues. And so our next step is really going to be to build out and leverage off the AHA registry and platform and become sort of more official than just sort of people that are just doing the best they can from this boots on the ground perspective.
Yeah, it reminds me so much of back when the COVID registry was created. James mentioned this 3-week time period to stand up the technology for the new registry, which frankly is unheard of. I've been around long enough to know how long it takes to create a technology platform. And the same thing was happening. Hospitals that were participating were using paper forms to collect data so that we didn't miss a thing. And then here comes the technology, and suddenly the exponential scale that can be achieved. And Kim, we so look forward to that exponential scale and being of assistance, to your colleagues in capturing data. I want to come back to Dan. You obviously have been a key part of the AHA's thinking about our involvement in this registry. For those of you who don't know, Dan previously served as chancellor at Ole Miss, where Division I sports loom large. And you've also, of course, studied all of the issues around racial and ethnic disparities with so many young athletes at top schools representing underserved communities. You likely have a perspective on the value of this registry for research and also for helping to improve equity for young people. We'd love to hear those thoughts.
Yeah, thank you. Thank you, Nancy. And equity is an important word here. There's, of all the things I've done in my life, I don't think I've found anything more frustrating and complicated than the relationship that universities have with the young men and women who come to take part in our athletic programs. The reality is that many of these young men and women come to us out of economically deprived communities and homes, and they come and perform on our campuses and generate millions and millions of dollars. And while they're with us, we're providing them the best healthcare available. And this registry offers an opportunity for another level of excellent care for these young athletes. And this opportunity to look into the window of the lives of these athletes and their families, what their healthcare was like before they came to us, and then what their healthcare will be over the lifespan, and the impact that that access to healthcare will make on their life can be really informing to us about social determinants of health. And then importantly, related specifically to athletics, gives us an opportunity to look at the pros and cons of health benefits long term. So you can imagine that some of our track athletes would have long, healthy life because of their exercise and their good diets. But if you look at the offensive and defensive line on our football teams, some of those young men come to us pretty heavy and are encouraged to be heavier while they're at our universities, and to understand the impact on their blood pressure, on their diabetes, on cardiovascular disease long term. This registry is going to provide an important opportunity for that. As James mentioned, the integration of data from different databases, the integration of data from our registry, then looking at databases that allow us to look at the long-term health outcomes of these student athletes will be rich in helping us to understand so many issues.
Yeah. And you think about the return of results back to participants, being able to share with these young athletes as they grow and develop, the findings of the registry and the calls to action that might provide people really significant. And so Kim, back to you. How do you see that this registry could help schools and sports programs at large understand how to handle a safe return to play for their athletes?
Yeah, I think that the scale of it is just really important. And so even if something's happening 1%, 5% of the time, still having that large scale can really help us decide on what are sort of proper, what do you need to do to make sure an athlete is safe as they return to play? What sort of testing do you need? And what sort of return to play protocols do you need to undergo? And I will mention, Dan, that Ole Miss was an early participator in our registry, and your team physician there was again a great collaborator. And one of the things that we've been particularly interested in is how our heavier athletes, so our offensive and defensive linemen, our throwers in the track and field are doing. And if we see that issue with obesity that you see in hospitalized patients carrying through to our athletes too, It does appear that exercise is protective, but it's something that we're keeping a close eye on. Although oftentimes when athletes have a big BMI, they're very, very musculature, and it's not the same. It's not analogous to a similar BMI in a non-exercising population. So very, very interesting opportunities and things that will come out of this registry and this collaboration.
Yeah, Kimberly, you would think
please,
by now, yeah, go ahead, Nancy, I'm sorry.
No, please.
Yeah, you would think we would know everything that we needed to know about the relationship between body weight and blood pressure, diabetes, and cardiovascular disease. But this registry is going to offer us an opportunity to learn some things that need to be learned outside of COVID for sure.
And, for parents of student athletes, I bet this is really heartwarming to know that this effort is underway. And Kim, I wonder if you had any thoughts about that, especially, in this COVID time or in general, how parents will treasure and value the study of these issues.
Yeah, I think that's a great point and a major concern. So I'm the mom of 4 boys, and our youngest son just got back on the football field last Friday night, and to see just the unadulterated joy on his face of being able to sort of participate with his friends and colleagues, it's just been awesome to watch. But at the same time, as a parent, you're concerned because you don't want to put your children in a situation which might create danger for them. And so, I think that one, understanding better what are the risks to participation, and we know that exercise and sports are really, really important, not only for the physical health of our young men and women, but also for the mental health of the young men and women. And so far, sort of up to date, we haven't really seen a lot of spread, particularly when people are outside between participants. Where we're getting the spread is when people are hanging out on the sidelines or perhaps in the locker rooms and things like that. And so I think that that continuing to sort of understand what we need to pay attention to in terms of symptoms as people come back after they've had COVID, what sort of workup is appropriate. And, that doesn't mean you need everything in the kitchen sink, because that creates barriers for under-resourced individuals or schools. We don't want to say you need the cardiac MRI. Sorry, there goes my AirPod. There goes
headphone, yeah.
And then create barriers so that people can't get back onto the field. And so, you need to find that nice balance where we can get people back to life, but get them back there safely.
James, before we open it up to our listener and viewer questions, I'm really anxious to know what you think about the new registry. You have spent your research career focused on early detection, risk assessment. So how will this registry really help us think about tragedies like sudden cardiac arrest and COVID in athletes from your point of view?
I think it's going to be transformative, and I congratulate Kimberly and AHA for launching this. To study things that happen, fortunately, rarely, like sudden death in athletes, you need to have a large sample size of very well characterized individuals to study so that you can understand these rare events when they happen. And, it's absolutely what's necessary to move from the tragic anecdote where you see it on the news or read it in the paper to understanding, what's driving these tragic events, and then obviously what can be done to prevent them. And at the same time, as Kimberly was mentioning, making sure that you don't restrict sport and activity from too many people on the basis of a borderline abnormal test. And so, what it takes is structure and detailed data collection, all the things that, the AHA has done for, as Dan said, 2 decades in terms of setting up registries. And it's that transition from the homegrown registry to this structured data collection with long-term follow-up that's going to allow real discovery here. And I see these patients as a cardiologist, and these are patients that have had we see them coming back, young athletes, their parents bring them with mild COVID. We see young athletes with minor abnormalities. They're among the most difficult things we ever deal with for all the reasons Kimberly said, and in part because we don't have the kind of data that we need to really provide advice to the athletes. And so, there's this balance where you're operating on, fear of a complication, but you don't have enough information to guide the athlete or their parents often. And so I think this is long overdue and well needed. And I can't wait to see this really expand and be the dominant registry in this space.
Fantastic. Thank you. Greg, I know we have had a number of questions come in during this past hour. I'd love to turn it back to you to hand those questions off to our guests today.
Happy to, Nancy. We always do, as you know. Thanks to you. Thanks to Dr. Jones, Dr. DeLemos, and Dr. Harmon so far for providing such critical insights. A reminder to our viewers and listeners, you can still join this conversation by sending your questions to aha@heart.org. And we'll open it up now, as Nancy says, to some of those questions. And I think some of our listeners, and this is absolute proof that people are paying very close attention to what you folks say on these programs. If we could try to turn it to the practical application of some of what's been our group has been discussing. And fascinatingly enough, we've got one here from an NCAA Division I athlete. NCAA D1 athlete here wondering how I can become part of this. How can I become part of this registry or a trial, or how can I participate in bringing this to life?
That's a great question. And so each school has the opportunity. We're taking information from whoever wants to give it. And so one thing that you could do would be to talk to your team physician, your athletic trainer, about whether or not they're participating and if they could participate. If they want to, they can just reach right out to us, and we're happy to take information and happy again to help them overcome some of the regulatory hoops. We actually are going to transition with the help of the AHA and the technology behind that, hopefully to a direct entry, to where your school wouldn't need to be able to having to participate, but that athletes could say, yes, I want to be part of this. I've had COVID, or I have an underlying heart condition, or I have diabetes, or whatever other condition as we sort of move forward. And so down the road, it's not available right now. We hope to have a direct sort of patient or participant entry so that you could do. But right now, I'd suggest working with your athletic trainer, and they can reach out to me directly, and I can guide them how to get involved.
Well, and you've opened the door, of course. As the parent of a student athlete who's recovering from COVID, this is really relevant conversation. You've been talking mostly about, or almost exclusively about, college-aged athletes, but will any of this registry information benefit high school students as well?
Yeah, that is also a great question. Yes, and so sort of step two, after we get the platform up and going and have some of these technological ways to incorporate high school students, is to have high school and even middle school youth athletes participate in this as well. And so we're sort of building this airplane as we're flying it, and we definitely do want to make sure that we're paying attention to younger athletes. And again, as a mom of younger athletes, I am also interested in us getting this information as well.
Nancy, you might want to bundle this with your entire panel. A lot of questions about the whole long hauler symptom situation and how the registry work in specifics might be able to help us discern. I mean, there's a story in this morning's New York Times about emerging information, people that have had COVID and known it, people that have had it and hadn't known it. How can all of this work that's being discussed here today benefit a deeper, richer understanding of what the long haulers are experiencing? And I think the panel would be, I think our audience would be interested in hearing what the panel has to say about what we know and what we don't know about the long haulers.
Okay, James, let's start with you. And what will it take to know what we don't know? I might add that to Greg's question as well.
Let me start by acknowledging that we know very little. We know that that patients after recovering from COVID often report chronic fatigue, a brain fog, exercise intolerance, chest pain, heat and cold intolerance, and then something we're seeing commonly that is called POTS, or postural orthostatic tachycardia syndrome. People who, when they stand up, get very dizzy and lightheaded. All of these are different components of a syndrome that happens in some patients unpredictably in the recovery of COVID, and that may last an undetermined period of time, but be long lasting. The NIH is launching an assault on this now, and actually we are aiming to participate and transition the AHA's COVID registry into a longitudinal follow-up so that we can use the hospital information and then track these individuals long-term, collecting blood and so that we can do blood-based studies over time and see whether the severity of the hospitalization, whether some of those blood biomarkers that I talked about predict whether patients have symptoms related to the heart or the brain long-term. The other way we're trying to get at this is we've already gotten approval to link our registry with Medicare data. And so that allows us a very easy way to track rehospitalizations and outpatient visits to doctors or even physical therapists, things like that may be seen in long COVID in our over 65 population. And again, through the ingenuity of the AHA's data teams, they're exploring other linkages with other insurance databases for younger patients. So we have two strategies to extend the reach of the registry to long-term follow-up. One is linkage with other databases, and Dan mentioned that, and the other strategy is to launch a prospective cohort study. But these are all going to require substantial resources, and I don't think we'll get all of that from NIH and other institutions. So for us to be able to do this, we're going to need resources. But these are tremendously important questions. That's the next wave of COVID science and potential impact of the pandemic that could last for quite a long time, of course.
And before I ask Dan to comment next on the same question, I will say that back in April or May, we started thinking about the importance of tracking these patients long-term, and resources really matter and focus really matters. And it's wonderful that our registry will allow us our existing registry will allow us an opportunity to give those individuals who are released from hospitals a chance to participate. And it's so important because of all the unknowns and the questions and the fear, frankly, people have that don't know what's ahead, that are experiencing some of the symptoms that you've described. Dan, what is your perspective?
This unknown about this virus does offer an opportunity for us to explore, for us to use the power of science to understand not only the virus, but cardiovascular disease. One of the things I think we'll learn from following these patients long-term is the complicated relationship between inflammation and cardiovascular disease. And I think the registry is positioned perfectly to help us to gain new insights. And none of us want to see a disease like COVID that has long effects. But if we're dealing with a disease that has long effects, then we need to leverage it for good. I think two key words, the two key concepts that James mentioned. One is the longevity of this process with the registration, and then also the linkage to other databases. And I'll tip my hat to leadership in the American Heart Association. They have been leaders in science in integrating databases to help us leverage better the knowledge that already exists in databases, but the ability to integrate databases and to analyze integrated databases in a good way.
Thank you, Dan. Kim, what is your perspective on the long hauler syndrome?
You know, fortunately, in our initial data, we are not seeing a lot of athletes with these long haul type symptoms. We're seeing, a few, but it really appears that exercise is protective for this, at least initially. And I think that that's a great message as we try to promote exercise in terms of well-being, is that it can be protective for many different things, not just COVID, but heart disease and diabetes and everything. And so, we're not seeing a whole lot of it. I think that that's great, but again, any sort of bad outcomes in this very young and healthy age group is concerning.
So, Dr. Harmon, you're not seeing a lot of long haul implications for athletes, but one of our other frequently asked questions today, I'm sure we'd like to hear from you and the other panelists, has to do with gender differences. What are we learning, if anything, about the ways in which COVID is affecting women versus men and vice versa?
Yeah. So right now we have a paper that's in review, and it addresses a lot of those things, but I'll sort of give you the sort of 10,000 foot view. We're not seeing it actually appears that females may be affected slightly more than males when it comes to sort of cardiac concerns and things. And so, again, we need to increase our numbers because this is a relatively rare occurrence. And so having bigger numbers and bigger participation will help us really suss out whether there are any sex differences or race differences. And also that interest in BMI is also interesting to us. And so we're looking at all those underlying demographics, trying to figure out if we're seeing outcomes. We also saw some increasing potential morbidity with Hispanics, which you see in the larger community as well.
Dr. DeLemos, do you have a point of view on that?
Yeah, there's an active proposal that there's a group that's looking at this question in our registry. I think it's a tremendously important question. I think what I expect we'll see is that we do know that women are hospitalized at a slightly lower rate than men, but very slightly. And we don't know yet, whether the factors that drive worse hospital outcomes differ in men and women. That's the focus of an ongoing analysis. But I think it's a tremendously important question. I think, what is most striking to me, frankly, having lived a year through this pandemic and all of us as humans and knowing people that have this, is just the randomness of it. I doubt that we're going to find that sex and gender are dominant determinants. I think that, what all of our listeners, probably have the same experience that, it's very difficult to, other than some of the cardiac factors that identify bad outcomes, that it can affect men and women in the same families in different ways and the opposite in different families. It's just a tremendously unpredictable virus. And for that reason, I think, we really all have to be quite careful.
Nancy, before I turn it back to you to get closing thoughts from your guests, so one other final sort of theme that has been pervasive from our viewers today, and no surprise, the American Heart Association has very active volunteers, is again the question of how can the average donor or the average volunteer, what can he or she do here to be helpful to the work that you all are undertaking?
Thank you, Greg. I think you have heard from our guest today a very sophisticated approach to knowing and understanding data that will truly make a difference in understanding the progression of COVID, why certain people get COVID and may get more sick from COVID. And we have opportunities in front of us that we've heard about today to expand our knowledge to individuals who have had COVID and following them in the long term, as well as to important populations to all of us, and that's our young people. And it takes resources to stand up these registries and to have the technology capability for the fast compute and data analysis that allows these studies to move as quickly as we've heard Kim and James and Dan talk about today. And so your financial support of this work will be so critical. We understand what we need to do to know and understand how we can play the biggest role scientifically. And it's the only rate limiting step for us is resources. So thank you for considering, as you consider your gifts, contributions to the American Heart Association to help spur this work. It will truly, truly save lives. And Greg, I'm going to now transition to our guests. And thank you, as always, Greg, for bringing forward the amazing questions from our viewers and listeners. We really appreciate them. And we want this to be an ongoing dialogue. So continue, please, to send your questions along. And I know that these three amazing leaders, as well as others in the AHA, would be delighted to answer questions. So as we wrap up this conversation today, I'd love for each of you to share your thoughts on this pivotal moment. In some regards, it feels like we're turning a corner on COVID-19. Yet, as we've talked about today, there's so much we still don't know. And we know that our registries are filling a gap. What is one big takeaway based upon the research from these registries and other things that are known in science that can help our viewers protect themselves and their families during this time? Dan, may I start with you?
Nancy, thank you. Am I off mute? Yes, I did at that time. So I want to say as I give my closing remarks, a word of appreciation to those of you who are listening to this story today. Thank you for your interest in the American Heart Association and for the work that we do. And on behalf of science volunteers, we could not be doing the research that we do without your support. So thank you. So as we are what some people might think are the waning days of COVID, don't we hope that we are in the waning days of COVID? The vaccine is being distributed, and the disease rates are beginning to go down, the number of people with infections. But we need to use this opportunity, the COVID registries, these two that we've talked about today, to prepare for the next pandemic. Will there be another pandemic? Yes, absolutely. It's not a matter of if, it's a matter of when this next pandemic will occur. The Heart Association will be better prepared because of the COVID registry for the next pandemic.
Thank you, Dan. James, what are your thoughts?
Well, I'd like to echo Dan's thanks to all of you for listening and for your support. This has been, launching this registry has been sort of a mission for the volunteers and for the AHA staff. We all felt like we had to do this. It was, obviously this has been the medical fight of our lifetimes. And we couldn't do this without your support. We certainly can't get to the next steps and address the questions that are going to face us and our families over the next 3 or 4 years without more support. I think, the message that I have for you is the same one I have for my families, is that my own family although it does feel like we're turning the corner, there's a lot of, unfortunately, there's a lot of suffering and death and disability left to come, because there's a lot of people that have to be vaccinated. It's going to take time. We have threats with new variants. And so now is not the time to let up, particularly given the uncertainty about the long-term effects of COVID. I think that we need time to see the investments in science in terms of the long-term complications of COVID really to come to bear before we loosen up too much with regard to social distancing and masking and all those things we want to give up because it's so disruptive and isolating.
Thank you, James. Kim, I'll give you the last word.
Thank you. I'd just like to sort of reiterate my thanks to the audience for taking the time to listen to us today. And, the athlete registry that we've built so far has been built primarily off of volunteerism and elbow grease to this point. And so we are so excited, again, to be connected with the AHA and collaborate with the AHA and really take this research to the next level. And, I do hope that we're seeing the light at the end of the tunnel with COVID, and that we can use this to springboard into all those other issues that also need research, like obesity and heart disease and hypertension in our young people, and what we can do to mitigate that and move forward in a healthy manner. And so thank you again for including me, and I'm very much looking forward to moving forward.
Thank you so much, Doctors Harmon, DeLemos, and Jones. I'm so proud to be standing beside each of you and working alongside you on these really important issues. And to all of our viewers, we're really proud to be standing alongside you. You are the faithful supporters of the American Heart Association. We are so grateful to you for your time and your treasure, and it enables this important work of the American Heart Association. I hope that everyone will stay safe and healthy. We look forward to connecting with you again in April for our next Connect with the CEO. Greg, back to you to wrap us up.
Thanks, Nancy. Thanks, Dr. Dan Jones, Dr. James DeLemos, and Dr. Kimberly Harmon for their time, and as has been said, for sharing such exclusive insights with this audience. And speaking of the audience, the American Heart Association thanks all of you for joining today. As you've heard from these experts, the need for continued research to help patients with heart disease, survivors of stroke, and millions of other people striving to live healthier, longer lives is needed now more than ever before, and we simply can't do it without you, our generous and dedicated supporters. Looking ahead, as Nancy says, mark your calendars and save the date for our next Connect with the CEO donor exclusive event. That'll take place on Wednesday, April 14th at 1 o'clock in the Eastern Time Zone, 12 noon Central. That's 10 a.m. on the Pacific Time Zone. Be on the lookout for more details coming soon. And that's it for today. Thanks for joining. Thanks for all you do to help ensure that the American Heart Association remains a relentless force for a world of longer, healthier lives. Watch for a complete replay of today's live event. It'll be coming to your inbox. Be well and stay safe.